Thank you for this very kind invitation. The topic today I'll be speaking on is surveillance following lower extremity arterial interventions. Given that this is the SFA popliteal section, I'll concentrate more on that. So I'll start out with a very interesting case, something that we all come across very often. It's a 60-year-old man who presents with right lower extremity claudication. He's undergone right SFA stenting. Now, post-stenting, how do we manage this patient? What do we do as a part of surveillance? How often do we evaluate the stent? Or even if we don't, should we even evaluate the stent at all? So one of the most important aspects is appropriate surveillance is probably the key to detect recurrent stenosis, recurrent disease, as well as stent complications. Surveillance is threefold. There's clinical assessment, which includes a focused clinical history physical examination that is pertinent to vascular etiology, hemodynamic or physiological assessment, which is ankle brachial index, specifically if the ABI drops by more than 0.15, that's indicative of worsening physiological evaluation. Lastly, anatomical assessment, in which nowadays duplex ultrasound is standard of care for surveillance purposes, given that it's cheap and it's safe. The rationale for using duplex ultrasound after these interventions is as follows. First of all, it gives you what your new baseline is. It helps you document what's your immediate anatomical and hemodynamic assessment or characteristics after an endovascular intervention. It helps you detect new site failures, in-stent restenosis or occlusions. It helps you detect if there's a new lesion or there's new in-stent restenosis. Lastly, it might help you provide thresholds when you can consider re-interventions in these patients. Now, when you do a duplex ultrasound for stent evaluations, we use a limited specific protocol. We assess with the short axis or transverse view, where you do grayscale and color flow, and then you assess the longitudinal or sagittal view, where you use all three, grayscale, color, and spectral Doppler. You start out with assessing the proximal native artery within 2 centimeters of stent, then you look at the stent edge origin, then you look at the proximal stent, the mid stent, the distal stent, and then the distal stent edge, and finally the outflow of this native artery within 2 centimeters of the stent. On grayscale imaging, you can identify intimal hyperplasia, atherosclerosis. On spectral Doppler, you can identify the peak systolic velocity, and also you should identify what the velocity ratios are. What is velocity ratio? Velocity ratio is when you find the highest peak systolic velocity at the stenotic site and then divide it by the peak systolic velocity of a proximal normal segment. That is called a velocity ratio or VR. This is very important in determining the percentage of in-stent restenosis and can help you guide your therapy in these patients. And then, of course, color Doppler can help you identify any filling defects as well. Lastly, we should realize that patent stents have higher velocities, especially in the SFA, compared to native arteries. And hence, if your peak systolic velocity is less than 190 centimeters per second or the VR ratio is less than 1.5, it is generally normal in SFA stents. Here's a nice evaluation of a stent placed in the popliteal artery for a popliteal aneurysm. This is 5 years out after the stent was placed. You can see the stent nicely attached to the vessel wall, and on color you can see the color nicely filling within the stent. Now this is the same patient, duplex, that was performed right after the intervention was done. So this is a duplex 5 years ago, and this is on the short axis. You can actually see the stent again here, and you can see the aneurysm that it's covering. This is an example of intimal hyperplasia, and SFA stent is present here, and you can see that there's a lot of significant filling defect, which is related to intimal hyperplasia. And on power Doppler, you can actually see the lumen that actually has blood flow in it. The peak systolic velocity over here is significantly elevated at 438, with monophasic appearing pathological waveforms. Here's just an example of a stent assessment. Here you can see the stent is in the SFA, so you look at the native proximal SFA, just proximal to the stent, with normal velocities and biphasic flow. You proceed on to look at the stent edge, where again you have normal velocities, biphasic flow, a little bit of mosaicism, proximal stent, normal findings, mid stent, again fairly normal findings, distal stent, normal findings. You look at the distal edge of the stent, again with fairly normal findings. and then the distal native artery just distal to the stent, again with fairly normal velocities and biphasic flow. When we look at studies to evaluate in-stent restenosis, there are very limited studies, and probably the most established study is this one done at University of Pittsburgh Medical Center. At UPMC, they evaluated 330 limbs and then looked at angiographic findings and duplex ultrasound findings and looked at potentially what peak systolic velocity and VR ratios have the highest sensitivity and specificity, as well as positive and negative predictive values. And what they found out was this particular criteria, where they saw that more than 50% stenosis was consistent with peak systolic velocity more than 190 with a VR of 1.5, and to identify more than 80% stenosis, peak systolic velocity of more than 275 and a VR ratio of more than 3.5 was typically seen. Another study performed at Columbia University, again using the same surveillance protocol, identified the highest sensitivity and specificity for more than 70% in-stent restenosis to be peak systolic velocity greater than 223 with a VR ratio of 2.5. Please note that the VR ratio was the strongest predictor in this particular study. They didn't find the same correlation when they looked at tibial interventions, and prior studies for aortoiliac interventions also have not found good correlations when you look at the duplex ultrasound findings and clinical outcomes. So this seems to work very well for femoropopliteal interventions, but may not as much for tibial and aortoiliac. This study actually tried to assess the natural history of in-stent restenosis in the femoropopliteal segments, or just post-stenting how the natural history is. They did only re-interventions in patients who had recurrent symptoms, regardless of the duplex ultrasound findings, but all received surveillance duplex ultrasound findings. And what they found out is that of the 94 limbs that they assessed, in 22 months, 25 had severe in-stent restenosis. Half of them did have recurrent symptoms, but about 9 of the patients were completely asymptomatic who had severe stenosis, and on a 10th-month follow-up, none of them required any re-intervention. No one went on to get CLI, severe claudication, or have stent occlusion. And hence, these authors strongly recommended that after endovascular intervention, re-intervention should not be pursued only based on the fact of duplex ultrasound findings, but also to look at clinical findings in these patients before you consider re-intervention. These are the several duplex ultrasound criteria that have been published so far by various institutions after femoropopliteal interventions for surveillance evaluation. The one that probably most stands out, the one that we have discussed, is the UPMC evaluation. Interestingly, the IAC, which accreditates vascular labs across United States, has actually accepted the UPMC criteria and in general recommend this criteria to be used to assess post-stenting duplex ultrasound evaluations for femoropopliteal stents. Going back to my case, he had a stent placed, but he left town immediately. 2 years later, he became symptomatic. He followed up with a local vascular specialist who identified in-stent restenosis and pursued with an angioplasty. He then stopped, did not follow up with him either, came back 2 years later back to my town, and then did see me. At that time, he was completely asymptomatic, but had his ongoing cardiovascular risk factors. Here's his ABI. You can see it's fairly normal with 0.99, with biphasic flow in the posterior tibial and monophasic flow in the dorsalis pedis. So there is certainly some disease there. We did a duplex ultrasound. The proximal SFA native artery has normal velocities with biphasic flow, but as we get to the proximal stent edge, we see the velocities go high up to 426 centimeters per second with a lot of mosaicism indicating severe in-stent restenosis probably here. Remaining of the duplex ultrasound findings seems to be okay. As you can see, his PSV was 426 with a VR ratio of 3.7. This indicates severe in-stent restenosis based on any criteria you utilize. What's interesting is this is an ultrasound finding almost 5 years ago. I continue to manage him medically. Mainly, I added silastazole for him as he was completely asymptomatic. 5 years of surveillance, he's continued to do fine with no progression of the stenosis to occlusion. And he seems to be doing okay. And this is where clinical evaluation, in addition to duplex ultrasound findings, is important before considering re-intervention in these patients. Here's another example with instant restenosis. Here you can see on B-flow imaging, you can see nice narrowing, very similar appearance to angiogram. And hence, when you want these kind of evaluations or assessments, doing B-flow or power Doppler can help you find the stenotic lesions well. Couple other waveforms to remember are these. When you see this severe sort of turbulent appearing waveforms, almost appears like Bart Simpson hair. This typically is indicative of severe stenosis just proximal to it. Another waveform to remember is this Parvus-Stardust-like waveform where you have dampened monophasic flow. This is typically seen after a severely stenotic or occlusion. And if you find this, there's probably some severe stenosis just proximal to it. Another complication that you might identify on ultrasounds as stent fractures, although not common, nowadays can be visualized if present. So in terms of surveillance, this is how I proceed with evaluating these patients. When we do an initial surveillance duplex ultrasound within a month for the SFA stents, if they have normal criteria, then we do a follow-up duplex ultrasound in 6 months and thereon. This is particularly in scenarios where the patients continue to stay asymptomatic. Now, after 2 years, if they are continuing to be asymptomatic with normal duplex ultrasound findings, then I'll just proceed with clinical assessment and ABI at that point. Patients are at 1 month ultrasound. If they have moderate instant restenosis and they are asymptomatic, then we'll do a follow-up duplex ultrasound in 2 to 3 months to assess for progression, and we may consider changing medical therapy. That could be intensifying their antiplatelet, antithrombotic therapy, or even considering adding cilostazol. In patients with severe instant restenosis who particularly have a decrease in ABI and change in symptoms, there is worsening symptoms, we would consider an intervention on that. Society for Vascular Surgery has also published guidelines, which is very similar to what we just reviewed in terms of approach. For femoropopliteal interventions after the initial surveillance, they recommend follow-up surveillance at 1 month, 3 months, and then every 6 months. So at the end, know what your laboratory or institutional criteria is for instant restenosis. If there isn't one, consider implementing one, perhaps the IAC criteria. Surveillance will always consist of clinical evaluation and imaging evaluations. Lastly, I think the role of duplex ultrasound is much better understood in femoropopliteal interventions. This is yet debatable in aortoiliac and tibial interventions. Thank you.